Hello, and welcome to the GRACE podcast series. My name is Denise Brock, and I am the Operations Director for the Global Resource for Advancing Cancer Education, or GRACE. In this podcast series, we interview patients, advocates, and healthcare professionals to provide the most updated information for our community and to highlight important issues facing those dealing with a cancer diagnosis. We hope you find this information valuable. For questions or comments, please visit us at cancergrace.org.
So importantly, what can you do? Number one, ask and advocate for next generation sequencing. You won't be able to have these discussions and get the most directed therapy without knowing the molecular status of the cancer. Number two, talk to your medical oncologist about the relative pros and cons of targeted therapy, because most of the settings that I've talked about are not FDA approved indications, and it's important to have these discussions. Engage patient advocacy groups to learn more about these therapies and connect with patients who are taking them, perhaps in the same setting that you're considering. And plan redundancy, please ask and advocate for next generation sequencing. If you have a localized cancer, you might see a lung doctor and then a surgeon, but never be referred to a medical oncologist. And so it's important to ask to see a medical oncologist, ask for next generation sequencing so that you can really determine the biologic nature of the cancer. So in conclusion, osimertinib improves disease-free and overall survival in resected stage 1B to 3A EGFR mutated lung cancer, and is approved for all patients with resected lung cancer with an EGFR exon 19 deletion or 21 L858R mutation. Trials of targeted therapy are ongoing for patients with surgery or patients after surgery, before surgery, and after curative intent chemoradiotherapy. However, can we already now extrapolate our approach of giving osimertinib after surgery to those with other types of driver mutations and to those after curative intent with chemoradiotherapy? I think the answer to this is yes, and we're already starting to do this for some types of subgroups of driver mutations. There are many important questions that remain, however, including what is the appropriate duration of treatment, who truly needs targeted therapy, who is cured by surgery with or without chemo. As I alluded to earlier, immunotherapy is not likely to be beneficial for most patients in this setting. And then I cannot stress the importance enough. Next generation sequencing to assess for driver mutations is critically important to determine the most appropriate treatment approach. And so with that, I thank you for your attention. I look forward to discussions. I include my email here. Don't hesitate to reach out to me with any questions you might have. Happy to help. Thank you.
Thank you again for joining us. This podcast was made possible by the generosity of sponsorship from our friends at Lilly and Exelixis. Please like and follow us on Facebook and Twitter. Send us feedback, share your story, donate, and visit us for more information at cancergrace.org. Thank you for listening.